on anterior chamber, a comparative study. The presenting author is Dr. S. Lakshmi.
Is it 4 or 5?
It's 4 minutes, is it there?
Please
Yeah.
stick to your timings.
Here it is 5.
So is the timing allotted 4 minutes?
It's a timing is 4 or 5. What it is printed is 5. Yeah.
4 minutes.
What have you prepared for? 4 or 5?
4 minutes.
4.
Yeah, it's written here.
No, it is written here. Here it is 5.
4. Let's stick to 4. Otherwise, we won't be able to complete. Yeah.
It's fine. It's 4 minutes fine.
Good evening, respected esteemed faculty members and everyone. Today I'll be presenting a paper on the topic effects of laser peripheral iridotomy and cataract surgery on anterior chamber angle parameters in primary angle closure suspect patients. Primary angle closure suspect has been found to have a much higher prevalence than that of primary angle closure. The first-line treatment for primary angle closure suspect includes a prophylactic laser peripheral iridotomy, which creates an alternative route for the aqueous to pass from the posterior chamber to the anterior chamber. While in cataract surgery, it helps by eliminating the thick anteriorly positional lens, which is considered to be the primary pathology in primary angle closure suspects. The study is a prospective comparative interventional study conducted in a tertiary care center of Assam from 1st January 2022 to 31st December 2022. Inclusion criteria includes patients diagnosed as primary angle closure suspects, patients with early cataract, that is opacification in the nuclear, cortical, and posterior subcapsular regions graded as 1 or 2. The exclusion criteria includes patients with evidence of a previous acute episode of angle closure, primary angle closure with peripheral anterior synechia, primary angle closure glaucoma, ocular hypertension, corneal abnormalities, and cataract obscuring the posterior segment, and prior intraocular surgery, and patients who were unwilling to enroll in this study. The patients were recommended either laser peripheral iridotomy or cataract surgery depending on their best corrected visual acuity. Patients with better best visual acuity better than 0.3 logma value were advised to undergo laser peripheral iridotomy, while best corrected visual acuity worse than 0.2 were advised to undergo cataract surgery. The cataract surgery performed was standard phacoemulsification procedure under topical and peribulbar anesthesia, and foldable posterior chamber intraocular lens were implanted after the procedure. All the participants underwent routine follow-up at day 1, first week, and 4th week after the treatment. Post-op, anterior segment OCT and gonioscopy were conducted at 1 month follow-up. And all patients underwent detailed eye examination, including the visual acuity assessment, IOP measurement using a Goldman applanation tonometry, a slit lamp biomicroscopy, static gonioscopy, optic disc examination with a 90D lens, and anterior segment OCT, where the anterior segment parameters were measured in all cases. These are the angle parameters that were included: angle opening distance, trabecular iris angle, trabecular iris surface area, and the angle recess area. Coming to the results, in total, 39 eyes of 33 patients were enrolled in the laser peripheral iridotomy group, and 37 eyes of 28 patients were included in the cataract surgery group. There were no post-operative complications at the end of the 4th week follow-up. In the cataract surgery group, all quadrants in all of the subjects had open angles after operation, while in patients post-laser peripheral iridotomy, about 12 eyes, that is 30% of patients, still had a residual angle closure in at least 2 quadrants, and 56% of the patient who underwent laser peripheral iridotomy had appositional angle closure in at least 1 quadrant. Here we can see post laser peripheral iridotomy, there is a change in the trabecular iris angle, while in case of cataract surgery, there is a drastic change post-procedure. And all the parameters showed drastic difference in the pre and post anterior chamber angle parameter changes. This is the table showing the comparison of gonioscopy before and after the laser peripheral iridotomy and cataract surgery. Here we can see post-cataract surgery, the Schaffer grading was found to be 4. In our study, the grade of the gonioscopic angle and the ASOCT findings were in agreement, indicating that both the interventions were effective in considerably widening the angle. When two groups were compared, cataract surgery was found to be superior to laser peripheral iridotomy in opening the anterior chamber. The changes in anterior chamber angle parameters that we observed in our study suggest that the careful management of the patients undergoing laser peripheral iridotomy or cataract surgery is warranted to minimize the risk of complications such as angle closure glaucoma. So we can conclude by saying that our study revealed that performing cataract surgery on patients with PACS was more effective than LPI in widening the anterior chamber angle. While both treatments led to a significant increase in angle width, LPI resulted in residual angle closure in 30% of eyes, while all patients who received cataract surgery had open angles in all 4 quadrants. This can provide a compelling evidence for future prospective randomized studies on this topic. These are my references. Thank you.
Did you see the lens thickness?
Ma'am, there was no option for finding the lens
Yeah,
thickness.
that's one of the most important thing nowadays that we do, where peripheral iridectomy is going to help or a cataract surgery. So try to assess that. The biometry nowadays gives us the optical
Yes, ma'am.
biometry. You
Axial
don't have
line-
to have an anterior segment OCT also for that.
Yes,
Yeah,
ma'am.
good.
Thank you, ma'am.
So our next presenter is Dr. Nikita Dash. She'll be talking on multiple subspecialty management in a complicated cataract surgery. Lesson for the aspiring surgeons.
Very good afternoon, everyone, esteemed judges and everyone present here. Today I'll be talking on multiple subspecialty management in a complicated cataract surgery, lesson for aspiring surgeons. So this is a case report of a 58-year-old female patient with a complicated cataract surgery that required multi-specialty management. She presented to our center after 10 days of left eye cataract surgery with diminution of vision and mild pain. When we examined the patient, there was corneal edema with flare and exudates, and there was a large unsutured temporal wound. But there was no hypopyon, surprisingly. Vision was PL positive, PR inaccurate, and pressures were 7. The chamber was shallow with flare and exudates, and the pupil was sluggishly reacting. So, and when we tried to do a very gentle B scan because there was a large unsutured temporal wound, and it showed a multiple low to moderate echoes suggestive of vitreous exudates. So our provisional diagnosis was a left eye endophthalmitis, and we planned for a pars plana vitrectomy in that eye. First of all, we started with suturing the wound before the PPV. Then, while we were trying to do a PPV, there occurred a hemorrhagic choroidal due to low visibility, and we had to drain it. Then there was difficulty visualizing due to small pupil and corneal edema. So we had to remove the epithelium as well as put in iris hooks in that patient for better visibility. And what did we see? An intraoperative surprise. When we were trying to remove all the inflamed vitreous, we saw a piece of a nucleus entangled in that vitreous. So after that, we had to do a very proper vitrectomy and ensure that we did a PVD induction so that we would be able to remove the nucleus fragments properly. And the nucleus fragments were then removed with the help of a fragmatome, and we checked for all peripheral areas of the retina to see that there were whether there were any breaks, and areas of retinal tears were properly lasered. Then there was a post-operative course. The patient had problems with poor corneal healing, so a cornea specialist were consulted, and we had to place in bandage contact lens in that patient to ensure better healing of the epithelial defect. Then patient later developed filamentary keratitis, which was again managed with lubrication, and from time to time we had to remove the filaments also with forceps for better healing. And finally her BCVA was, it improved to 6/60. And but still there was a poor ocular surface, so we had to prescribe ongoing lubrication in that patient. So it has been discussed that prolonged cataract surgery, vitreous loss, and complications are well-known causes of corneal decompensation. And along with it, poor ocular surface can lead to a delayed epithelial healing in cases of debridement for visualizing purposes. And usually if when we are dealing situations like this or cases like this which requires which have multiple complications in them, so these kind of cases require a multi-pronged approach with respective subspecialty management. So I would like to conclude that we should always respect our ocular tissues and modify our technique or management accordingly and act in the best interest of the patient. Thank you.
Just wondering, with the B scan, there was no nuclear fragments that could be detected as such?
So actually it was totally like um, it was totally wrapped in that exudates of that vitreous exudates. So we could, I think there might have been spikes, but we could not exactly differentiate it from the vitreous spikes because the entire vitreous was inflamed. So when we started removing the inflamed vitreous layer by layer, it was at one place that the nucleus was stuck. Where we got to see it.
Okay, good.
Thanks.
Thank you so much. The next presenter would be Dr. Parnika Wallard, and she'll be speaking on association of intraocular pressure and retinal nerve fiber layer thickness in pseudoexfoliation patient.
Good evening, everyone. Moving on. Pseudoexfoliation syndrome is distinguished by the evolution and the growing accretion of fibrillary deposits. It's characterized by the presence of white fluffy dandruff-like material on the pupillary border, lens capsule, or the angles. Apart from raised IOP, various pressure-independent factors like the impaired ocular and retrobulbar perfusion, abnormalities of elastic tissues of lamina cribrosa, and the increased protein concentration of aqueous humor, deposition of melanin, and pseudoexfoliation material. These are the main risk factors for the loss of retinal nerve fiber layer with subsequent glaucomatous damage in pseudoexfoliation patients. Space domain OCT is a rapidly evolving, robust technology which provides high resolution, quantitative, and reproducible measurements of RNFL and retinal ganglion cell complex, having high sensitivity and specificity in early glaucoma diagnosis. So the aim of our study was to see the association of intraocular pressure and retinal nerve fiber layer thickness in pseudoexfoliation patients. It was a cross-sectional study conducted at a tertiary care center for a period of 6 months. 60 cases were included. Presence of pseudoexfoliation material was mandatory, and patients having any media opacity interfering with the visualization and OCT image capturing, high myopes, and patients on anti-glaucoma medications or having undergone any previous glaucoma and cataract surgery were excluded. Anterior posterior segment evaluation was done. Intraocular pressure was calculated using Goldman applanation tonometry. OCT RNFL, gonioscopy, and pachymetry was done. A case report form was filled, and the data was analyzed. PXF is a complex systemic disorder of extracellular matrix primarily affecting the eyes and visceral organs, characterized by the deposition of fibrillary material on all anterior segment structures. It's one of the most common causes of secondary open-angle glaucoma. It's a well-known, OCT has a very well-known role in diagnosing the pre-perimetric glaucoma. So prevalence of PXF increases markedly with age, and in our study, 60% of the patients were females with the mean age being 66.5 years. Since it was conducted at a tertiary care hospital, the results couldn't be implemented on a general population. Furthermore, since glaucoma is a progressive disease resulting in progressive loss of nerve tissue with optic nerve head and visual field changes, so testing at a single point in time cannot be conclusive. More population-based prospective studies in our setup evaluating the changes over time need to be conducted. Out of 60 patients, we had 36 females and 24 males. The mean age was 66.5 years. And according to our, thus it can be interpreted from the study that there was no correlation between RNFL thickness and IOP in PXF patients. Patients with decreased corneal thickness, central corneal thickness, increased intraocular pressure, having grade 3 PXF and pigmentation in the trabecular meshwork have greater risk of progression from pseudoexfoliation syndrome to pseudoexfoliation glaucoma. And routine assessment and follow-up of PXF patients with OCT will help in an early diagnosis of PXF glaucoma. Thank you.
So our next speaker is Dr. S. Lakshmi. MS Lakshmi. The title is Refractive Outcome of Ciliary Sulcus Implanted Intraocular Lenses.
Good evening, everyone. There is nil financial support and sponsorship. Introduction. Cataract surgery is the most commonly performed surgical procedure in ophthalmology, and posterior capsular rent is a common, potentially sight-threatening intraoperative complication with an incidence of 0.2 to 14%. Even though advanced techniques, instrumentation, and technology has reduced the rate to 0.45 to 5.2%, and in experienced hands it is reduced 0.45 to 3.6%. Optimal location for IOL implantation after successful cataract extraction is within the capsular bag, closer to the nodal point with great stability and resulting in a better image resolution. The placement of IOL in the ciliary sulcus is preferred in case of PCR, zonular laxity, lens subluxation, or planned piggyback intraocular lenses. So sulcus implanted IOL has a more anterior effective lens position, showing a myopic shift from the preoperative predicted value, producing a suboptimal visual outcome in some patients. So generally, surgeons empirically subtract 0.5 to 1.5 diopter from the IOL power calculated before surgery. So the primary objective was to determine the difference in the preoperative predicted and postoperative spherical equivalent refractive shift, and to determine the difference in the IOL power for in the bag implantation and the ciliary sulcus implantation, and to assess the intraoperative and postoperative complications. So this prospective interventional study was conducted on 77 patients fulfilling the inclusion criteria in the Department of Ophthalmology, Jalpa Hospital and Research Center, Kola, Karnataka, from September 2022 to December 2023, after obtaining approval from Institutional Ethics Committee and CTRI and written informed consent from the subjects. Inclusion criteria was all cataract patients of either sex more than 40 years of age with capsular rupture, whether it's anterior capsular tear without extension, anterior tear extending to posterior capsule, and posterior capsular tear with intact anterior capsule, zonular dehiscence, weak zonules in case of pseudoexfoliation, uveitis, or traumatic subluxation of lens. Patients with these patients were excluded, that is lack of anterior capsular support, patients on any topical anti-glaucoma drugs, patients with lacrimal gland and drainage disorder, history of any ocular surface surgery, ocular trauma, and thyroid disease patients. So after obtaining demographic data, each patient underwent the standard protocol for cataract evaluation and surgery. Once PCR was noted, the lens capsule bag was assessed, and in patients with sufficient anterior capsular support, IOL was implanted in sulcus after reducing 0.5 to 1 diopter from the power calculated by the SRK2 formula for in-the-bag IOL implantation. And data was entered into MS Excel datasheet and analyzed using SPS2 22, and paired t-test is a test of significance. So the results were, there was 20 males and 56 females. Mean age in years was 63.50, mean axial length was 22.51, mean planned IOL power was 22.04, and mean sulcus implanted IOL power was 21.50. The pre-predicted spherical equivalent refraction mean was found to be 0.0108. Postoperative spherical equivalent refraction was mean was 0.0586, and p-value was found to be less than 0.001, which was statistically significant. The virtual IOL power was in mean was 21.50, and the sulcus implanted power was 22.046, and the p-value was found to be 0.001, which was found to be statistically significant. And this graph shows the cumulative distribution of spherical equivalent refraction after IOL implantation in the sulcus. The preoperative mean the pre-op visual acuity mean was found to be 1.039, And post-op visual acuity was found, mean was found to be 0.346 and standard deviation 0.269. Post-op 1 week visual acuity was, the mean was 0.246 and standard deviation was 0.194. And post-op 1 month was 0.189. And p-value was found to be 0.001, which was found to be statistically significant. Seeing the logmar post-op visual acuity, that is almost 74 patients had good outcome. Only 3 patients had was in the range of borderline outcome in post-op patients, and no post-op patients had poor outcome. And p-value was found to be 0.001, which was statistically significant. 38 patients in the stage in which PCR has occurred most commonly was during the cortical wash, that is 38 in 38 patients, followed by hydrodissection and nucleus prolapse. The complications, 11 patients had striate keratopathy, followed by endothelial pigment dusting and IOL pigment dusting, followed by iritis and CME, which was subsequently managed during the postoperative period. Most of the patients had good visual outcome, falling in the good outcome visual category of WHO classification. So during cataract surgery, placing the IOL in the ciliary sulcus requires decrease in the lens power, and this is due to the myopic shift of the optic that increases effective power. So the greater the power, the greater the difference. Thank you.
About the choice of IOL, that should never be single piece. That's a very important, otherwise you could end up with a lot of uveitis and efficient syndrome and a lot of other things. So it is mandatory to look for the IOL, and you should have a backup of 3-piece IOL at any cost. Maybe you have to go no way out, even for very simple Indian lenses, you may have to give a Alcon 3-piece lenses. That is very important. You have to save your skin as well as of the patient. Both are important.
Just one question. Was it a single surgeon study with a single type of IOL, or was it done by different surgeons?
It was done by different surgeons.
So, but the outcome was more or less the same in all the surgeons,
Yes, sir.
irrespective of it, and with a single type of IOL.
Single type of lens.
And in no case was the wound size increased.
No, sir.
Okay, thank you.
I noticed that one of the inclusion criteria was individuals who had an anterior capsular tear with intact posterior capsule. So you can place an IOL in the bag. Why was the IOL placed in the sulcus in that case, if the posterior capsule is intact?
Extending to the posterior capsules.
Extending. So the posterior capsule is not intact, that means.
Not in that. It was.
Okay. And also in the
extending to the posterior capsules.
extending to the posterior. Also, and also you mentioned that zonular laxity also you would prefer implanting a lens in the sulcus. I mean, I think most of us would prefer implanting it in the bag after stabilizing the bag with a capsular tension ring or any of these modalities, isn't it? Okay, thank you.
The next presenting author is Dr. Jayashree Kedia, and she'll be presenting on comparative analysis of phacoemulsification and MSICS in patients with pseudoexfoliation. It seems that she is not around. Is Dr. Purendra Bhasin around? No. So can we go over to Dr. Koel Chakravarti? Fine. She is around and she'll be presenting a clinical profile and outcome of secondary IOL implantation in a tertiary institute in Eastern India.
Good evening, everyone. My study is in the clinical profile and outcome of secondary IOL in a tertiary care institute in Eastern India. So surgical management of aphakia has evolved over the last few years, and the current methods include scleral fixated IOL, iris claw lens, and the novel CMT flex lens. But there is lack of data regarding the visual outcome and complication of these techniques. We conducted a prospective observational study, which was single-center based. The patients with unilateral aphakia were included, and they underwent secondary IOL implantation between January to December 2023. The patients were followed up for 6 months, and statistical analysis was done using SPSS version 23. The parameters analyzed were visual acuity, intraocular pressure, anterior chamber reaction, central macular thickness, and the post-op complications. So we had a total number of 60 patients, of which majority, that is 73%, were male, having a mean age of 55 years. History of trauma was present in 55% of the patients, and right eye was operated in 51%. Most common comorbidities present in the study cohort was hypertension, followed by type 2 diabetes. The most common lens that was used in our cohort was SFIL in 63% patients, followed by iris claw in 25% and CMT flex lens in 12%. Coming to the baseline characteristics, the most common comorbidity was type 2 diabetes, which showed a statistically significant difference between the SFIL and the iris claw group, and a history of trauma was also significant between the two groups. So when we plotted the change in visual acuity over time, it showed a statistically significant difference over a period of 6 months, with the most drastic change in the first 7 days. Between the two lens categories, the difference was also statistically significant. Now, the IOP and the CMT on postoperative follow-up did not show any statistically significant difference between the SFIL and the iris claw groups. Coming to the post-op complication, which was seen in 30 patients, the most common was cystoid macular edema in 43% of the patients, followed by epiretinal membrane in 17%, hyphema in 13%, foveal atrophy in 10%, IOL dislocation, posterior IOL tilt, and retinal detachment were the minor complications. So when comparing between the two groups, SFIL versus iris claw, there was a statistically significant difference, the SFIL group having the more complications. AC flare more than equal to 1 was seen in the iris claw group on POD1 with no significant difference on follow-up. And none of our patients had severe iridocyclitis, which was defined as AC flare more than equal to 3. When we adjusted for the history of trauma, the rate of complication was higher in the SFIL patients who had the history, which is statistically significant. But for the iris claw patients, after adjusting for trauma, the difference was not significant. So cystoid macular edema was the most common complication, which was seen in 21.7% of our patients. But between the two lens groups, it was not significant. There was no association with trauma. And out of 13 patients, 8 of them with non-resolving CME received a posterior subtenal injection at the dose of 40 mg per ml, and 1 ml was injected, the standard procedure. So the effect of PST on the CMT was plotted after 1 month, and there was a reduction in the CMT, which was statistically significant compared to those who did not receive the PST. Comparing our study with the other studies, by Madhivanan N. et al. In the Indian Journal of Ophthalmology, there was a retrospective study over 104 patients in 5 years. They showed a better visual acuity in SFIL group at 1 month, but it was similar in both the groups at 1 year. But they had a most incidence of postoperative iritis and IOP spikes in the iris claw group. And the most common complication they encountered was transient hypotony, which was not there in our study. Coming to the other similar study by Navya C. et al., they also analyzed SFIL versus iris claw group, and they showed a drastic improvement in the visual acuity at the end of 6 months. And the most common complication they encountered was striate keratopathy and pupillary ovalization. So in our study, we see that visual outcome and intraocular pressure variations were similar between the two lens categories, but the complication rate was higher in the SFIL group who had a history of trauma. CME was the most common complication with significant reduction after PST. AC flare, though higher in the iris claw group initially, was similar in follow-up with no cases of severe iridocyclitis. So the strength of my study was it was a prospective study. The complications were analyzed. We measured the CMT, and the effect of PST on CME was also analyzed. The limitation was it was a short follow-up of 6 months. It was a small sample size of 60 patients only and single center based. So concluding, SFIL and iris claw lens are similar with respect to visual outcome. Complications are higher in those who have history of trauma, and CME is the most common complication with significant improvement with PST. Thank you.
Good presentation. I was just wondering, was maybe I missed it, was the case selection randomized on who was undergoing iris claw and who was undergoing scleral fixated lenses?
No, it was a standard means we selected based on the patient's age and whether the patient was suitable for SFIL or iris claw. And a few patients who could afford the CMT flex, we had put in those.
Okay.
But for analysis, we included the CMT flex and the SFIL, that is the XNIT technique, We included them together in the SFIL group for analysis.
And what was the age criteria that was followed for choosing between iris claw and scleral fixation?
Usually the younger patients, they were put SFIL and elderly iris claw.
Okay, so it was not an exact age group that
No,
was
no,
defined
no.
for selection, but for this particular study.
No.
So that means the type of IOL, what IOL you are about to present was decided on the table itself? Or had you
No,
pre-planned
no,
it?
no. We
All
did
these
a
were-
secondary procedure.
All these were aphakic patients?
Yeah, yeah, yeah. They were all aphakic patients.
We have the last speaker,